You're listening to Medscape's in-discussion series on Cardiorenal Metabolic Syndrome, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Nihar Desai. Dr. Desai is an associate professor of medicine and vice chief of the section of cardiovascular medicine at Yale University School of Medicine. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hi, I'm Dr. Nihar Desai from the Yale School of Medicine. Welcome to Season 1 of the Medscape In Discussion Cardiorenal Metabolic Syndrome podcast series. Today, we're discussing the management of dyslipidemia, focusing on triglycerides and high-density lipoprotein cholesterol. I'm absolutely delighted to have our expert guest, Dr. Pam Taub. Dr. Taub is professor at the University of California, San Diego School of Medicine in the Department of Cardiovascular Medicine. She's the founding director of the STEP Family Foundation Cardiac Rehabilitation and Wellness Center. Pam, delighted to have you. Thanks for joining us on the podcast.
Well, it's a pleasure to be with you and to discuss some of my favorite topics, including triglycerides and HDL.
Thanks so much, Pam. So we know, and we've had a number of episodes in this podcast series, obviously focusing on the CKM syndrome. We've spent a lot of time discussing dyslipidemia broadly. We even had a dedicated session on low-density lipoprotein cholesterol. And so here we really want to focus with you on triglycerides and HDL and get our audience, really up to speed. Let's sort of start off and take on triglycerides to start here. Can you take us a little bit through the history, some of the older trials that suggested a benefit to triglyceride lowering, maybe some mixed trials in the statin era, and then what were some of the big questions that remained, in particular, this sort of unique subpopulation, if you will, those individuals with elevated triglycerides and low HDL, maybe that was sort of a particular population of interest. So can you take us through a little bit of that history for the audience?
So we have seen from many epidemiological studies that there is an association between elevated triglycerides and cardiovascular risk. Most recently, the ERIC study looked at triglycerides in the population, and it showed that even when your triglycerides are over 100, that cardiovascular events increase. So we've seen all of these epidemiological studies that are showing an association between triglycerides and cardiovascular risk. So then the question is, can lowering triglycerides actually reduce cardiovascular events? And early on, we had studies such as the Helsinki Heart Study that showed agents such as gemfibrozole were beneficial. But then subsequently, we had more contemporary studies such as a cord lipid in which we had fenofibrate added to simvastatin, and we didn't see as much of a benefit. So some early studies showing benefit, but in the newer studies, when triglyceride lowering is put on top of statin therapy, we're not seeing as much of a benefit. Most recently, we had the Prominent study, which was a really well-done study of over 10,000 patients, and the median triglyceride level was about 270, and you had a pretty potent lowering of triglycerides, about 26%. And with this fibrate, we didn't see a benefit in terms of improvement in cardiovascular outcomes. And so a lot of people are wondering, why are we not seeing the translation of this association that is very clear to a benefit in clinical trials where we are lowering triglycerides? And one of the key hypotheses is that when you look a little bit closer, it is what is actually happening in terms of ApoB, which is a marker of atherogenic lipids, that when you don't have ApoB reduction, you don't have a translation into improved cardiovascular outcomes. So in the Prominent trial, even though there was a significant lowering of triglycerides, you didn't see a reduction in ApoB. And this is what most people hypothesize is why that trial was negative. So the other concept when we think about triglycerides is you need to think about triglycerides as the atherogenic milieu. So you don't see typically an isolation in triglycerides alone without other concomitant biomarker elevation. Typically, the patient that has elevated triglycerides also has metabolic syndrome, so they tend to have a lower HDL. They tend to have insulin resistance, hyperglycemia, and many times these are patients with type 2 diabetes. So that's kind of the milieu in which you see elevated triglycerides is in this patient that has evidence of metabolic syndrome. And so that is one important aspect about triglyceride lowering that we need to think about is the holistic patient. It's not just that we need to focus on triglycerides, but we also need to treat the other concomitant factors such as the type 2 diabetes. And the other factor that we really need to think about in our approach to these patients is this concept of residual risk, of which triglycerides contribute a significant component. When we talk about residual risk, what we're referring to is patients that despite the LDL being in optimal range, they still have events. And a lot of those events are thought to be due to other biomarkers such as elevated triglycerides and lipoprotein A.
Yeah, Pam, thanks so much. I mean, there's so much there that, I know the audience will find compelling. So we had this epidemiology. We continue to have this epidemiology, right? These observations of elevations in triglycerides being associated with an increased risk of cardiovascular events. And then to your point, the story gets a little bit more complicated, that maybe pharmacologically modifying triglycerides hasn't consistently been shown to be beneficial. I think there was a big question in kind of the statin era, whether there was continued benefit or if there was a benefit to triglyceride lowering with fibrates. And then the prominent trial, to your point, the headline, if you will, was that the fibrate in that pemafibrate wasn't shown to be effective. But I think you rightfully then get into some of the nuance of it's probably what's going on with ApoB. We know again from epidemiology that that's a very important marker for cardiovascular events. And so the fact that we didn't see a dramatic reduction in ApoB in prominent might be part of the explanation here. And so I think the triglyceride story, to your point, is one that continues to evolve. And I have to say, given the focus of this podcast series and the cardiovascular, kidney, metabolic syndrome, and what's happening to the prevalence, if you will, of many of the other diseases and kind of comorbidities that we're talking about here, that hypertriglyceridemia is something that we will continue to see in our clinical practice. And so as we shift a little bit away from maybe fibrates and prominent, Pam, do you want to make a comment about any novel triglyceride lowering therapies, sort of what's on the horizon and what might the audience be hearing about in the weeks, months, and years ahead, just given how common and prevalent hypertriglyceridemia continues to be?
There is one agent that we should talk about, and that is not novel, that's on the market, and that's icosapent ethyl. There was a landmark study called the REDUCE-IT study in which they took over 8,000 patients who were on statin therapy, but were either considered to be high risk or had established atherosclerotic cardiovascular disease. And that study had a pretty significant absolute risk reduction of 4.8% in terms of major adverse cardiovascular events. And it was very impressive results. The average triglyceride level in REDUCE-IT was about 216. But what's really interesting about REDUCE-IT is the triglyceride lowering was only about 20%. So it wasn't a dramatic lowering of triglycerides, but there was a 10% lowering of ApoB. There was also a reduction in high sensitivity CRP. But what's even more fascinating about REDUCE-IT is when you look at people with triglycerides over 150 versus those with triglycerides less than 150. And if you look at those two groups, both groups get benefit. So that really speaks to other mechanisms other than just pure triglyceride lowering that led to the cardiovascular benefit. And one of those theories, again, is ApoB and maybe some reduction in high sensitivity CRP. So Reduce It is not without controversy because there are other trials such as Strength in which we didn't see any improvement in cardiovascular outcomes. And there's a lot of nuances on why those two trials are different. Many will say, well, they're two different molecules. Reduce It is pure icosapent ethyl, while Strength, the compound, was a mixture. So that might be one of the reasons why there's a difference in the trials. The mechanisms are not completely related to triglyceride lowering. It would be really amazing if we could have more trials with icosapent ethyl to really understand some of the underlying mechanisms. But we do have a lot of other agents on the horizon that are very promising. So one of the most promising agents is an agent called plozasiran, which is a small interfering RNA that acts against ApoC3. And in some of the phase 2 trials, you had a 50 to 60% lowering of triglycerides. And so this is a very potent drug. And I think it will really answer the question if there is cardiovascular benefit with this agent, whether triglyceride lowering is going to be beneficial. So that phase 3 study is called Capitan, and that is going to be starting pretty soon. And it is a cardiovascular outcomes trial. And I think it will finally settle the issue of, does triglyceride lowering lead to improved cardiovascular outcomes?
No, that's great. So certainly, lots for the audience to stay tuned for on the triglyceride story. I might ask you, Pam, because I think that you very nicely laid out some of the data and then also some of the lingering controversy for the fish oils and these sort of prescription grade fish oils. And, is icosapent ethyl something special and unique under the brand name Vascepa? Because as you pointed out, the combination of DHA, EPA in the Strength trial didn't show a benefit. What are we to sort of make of that? I like you, found the data from Reduce It to be quite compelling. I mean, absolute risk reductions of almost 5% in the primary endpoint. And I think very important directional consistency for many of the important secondary or component endpoints as well. One practical question for you: how are you using icosapent ethyl in your practice? I mean, give us a sense of, how you sort of think about it. What's the patient profile that you might suggest it for? And in a complementary way, is there a role for over-the-counter fish oils? Do you ever recommend those to patients that want to go to their local health food store or the vitamin store and just get something off the shelf? Maybe give us and the audience some sense of that.
In my clinical practice, the way I use icosapent ethyl is really in those patients that have residual risk. So the first thing that I always do is maximize the statin. And let's not forget that statins have triglyceride lowering effect as well. And so when you maximize the statin, you are going to see significant lowering of triglycerides. In addition, we also have other agents such as the PCSK9 inhibitors that also lower triglycerides. So some of our patients who need potent LDL lowering are going to get this concomitant lowering of triglycerides. And so when I use it in clinical practice, it's really looking at patients that meet the Reduce It criteria. So they are optimized on statins, and yet they still have elevated triglycerides. And to me, elevated triglycerides are really not high in the 300, 400 range, but anything really over 150 is elevated triglycerides. And so in those patients that have high risk, that are having multiple recurrent events, it is very reasonable to use icosapent ethyl to address that residual risk. And that's per the guidelines as well. In the most recent reiteration of our guidelines for chronic coronary disease, it is recommended that we can use icosapent ethyl after patients are maximized on statins. In terms of over-the-counter fish oil, you do have to be very cautious because those agents are not FDA regulated. And a lot of times you're not really getting what they say that you're getting. and there can be other ingredients in those compounds, and it's not been tested in a rigorous clinical trial. So for our patients with established atherosclerotic cardiovascular disease, I do not recommend these over-the-counter agents, and I will give them the prescription version. We have to be really cautious on what we recommend to our patients because these are agents that are not regulated by the FDA. They're not subject to randomized clinical trials and just don't have the level of evidence that our pharmacotherapy that has been subjected to rigorous clinical trials have. And so I don't recommend these, especially for our patients with established atherosclerotic cardiovascular disease. But there are many patients who fall into the category of primary prevention that really want to do everything that they can to optimize their overall cardiovascular health. And what we've seen is agents such as EPA are beneficial. And the best way to get EPA is to consume healthy fish such as salmon. And we know that when people consume it in their diet, it's way more bioavailable than what they get in their supplements. So what I joke with a lot of my patients about when they take a lot of supplements is many of these supplements are not bioavailable and you're just paying for expensive urine. So better to get a lot of these beneficial compounds through your diet.
Yeah, Pam, thanks so much. As we kind of get into the next phase of this discussion, I want to move away from triglycerides a bit and move on to another lipoprotein subfraction that's generated a lot of discussion and back and forth, and that's HDL. There's been so much enthusiasm about HDL, and then I think we have to say that a series of very disappointing clinical trials, whether that be for niacin and niacin-based therapies to the CETP inhibitors, and then most recently the ApoA1 infusion that was tested in the Aegis 2 program. Pam, maybe give us your sense of, again, the epidemiology of HDL and cardiovascular events, some of the trials that we've seen, how that has shaped your practice, and then what are you looking forward to? And I might specifically ask for your comments on obicetrapib, the final remaining, if you will, CETP inhibitor. What should we be looking out for there?
Again, the HDL story is very similar to the triglyceride story in that we've seen so much great epidemiological evidence that high levels of HDL are cardioprotective. Yet the clinical trials have been very disappointing. And the most prominent one with a cholesterol ester transfer protein or a CETP inhibitor was torcetrapib, which we had so much hope for. But that trial was negative. And one of the thoughts is that torcetrapib had what we call off-target effects in that it did raise blood pressure and it also increases aldosterone levels. So there is excitement still for that category of drugs that raises HDL. We need to go back to ApoB because the new compound that is currently being tested in clinical trials is obicetrapib, which has other properties other than just raising the HDL. And that includes the lowering of ApoB. And with some of the data that we've seen from the phase 2 trials with obicetrapib, we see about a 30% lowering of ApoB, around a 46% lowering of LDL, and very, very interesting is about a 57% lowering of lipoprotein A. So this is all on top of increasing HDL. So again, a very pleiotropic compound, but I really like that it also has that ApoB benefit. So I really think that there is great possibility that the phase 3 outcome trials are going to be positive with this compound. So we have to keep in mind that just because one compound in the category results in a negative trial, we can't dismiss all of the other compounds, and we have to give each compound its due respect because as you see with obicetrapib, there's other pleiotropic benefits that we are seeing. So I don't think the HDL story is dead. The other really nice aspect of HDL that we're learning is just more HDL biology. So there are lots of people that have very, very high levels of HDL. So we see sometimes in our clinical practice, people that have HDL levels in the 100 range. And what we're learning with more detailed analysis of HDL, looking at HDL particle number and HDL function, is sometimes that HDL particle is dysfunctional. And so even though these people have very high levels of HDL, it doesn't translate into the protective benefits of having high HDL. So I think in the future, our analysis of HDL isn't going to be just looking at pure HDL, but we are going to be looking more at HDL particle number and actually HDL particle function when we analyze our patients with elevated HDL.
Oh, that's really interesting, Pam. And it sounds like we've got much to unfold still on the HDL side of the story here too. And so we've had some disappointing results thus far, as you said, but I think we still have some hope. And maybe obicetrapib is going to be that kind of next therapy for us, not only because of its impact on HDL, but also, as you noted and told us about, the important reductions in LDL and in ApoB. That might be something that ties all of this together, whether we're thinking about triglycerides, whether we're thinking about HDL. Maybe that activity, maybe that pharmacological effect is something that we've got to hold out some hope for. And so maybe that'll be the obicetrapib story.
One other thing that I wanted to add, getting back to what you said, Nihar, is the context of which we're taking care of patients with cardiometabolic syndrome is really the more holistic perspective as advocated by the AHA presidential statement on CKM. And similarly, when we're taking care of patients with hyperlipidemia, it really needs to be a more holistic approach. It can't just be focused on LDL or HDL or triglycerides. It needs to be all of those parameters, but also the context of that patient that has obesity, that has type 2 diabetes. And when we're looking at these molecules that seem to be beneficial, what you're seeing is a common theme. It's not just that they're impacting one parameter, but that there's multiple parameters that they're impacting, such as ApoB. And so again, we have to have that holistic approach to lipid management.
Yeah, I think, Pam, that's such a critical point. And I think you made it very, very compellingly that we think about CKM as kind of, interrelated and really thinking holistically about how to approach a patient with various manifestations of CKM syndrome, that I think we have to think about lipids in very much the same way, that it can't be an isolated focus on LDL or triglycerides or HDL, but comprehensively, what do we think about the role of hyperlipidemia or dyslipidemia in someone's health and cardiovascular health status, and what's the best set of interventions, obviously lifestyle, pharmacological, and others, to try and get them in a better place. And so I think your point there is very, very well taken. Pam, I want to thank you again for joining us today. It was a really great discussion, and I really appreciate you kind of sharing these insights with our audience. So today we discussed the management of dyslipidemia and focused in on triglycerides and HDL cholesterol with our special guest, Dr. Pam Taub from UCSD. I'll also just remind you to please take a moment to download the Medscape app to listen and subscribe to this podcast series. I will thank you again for joining us. Again, this is Nihar Desai from the Yale School of Medicine for the Medscape In Discussion Cardiorenal Metabolic Syndrome podcast series.
Thanks for listening to Medscape's In Discussion Cardiorenal Metabolic Syndrome podcast series with our host, Dr. Nihar Desai. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on cardiorenal metabolic syndrome.